courses has also reduced significantly from 1,300 and whatever to about 471 or less. We have still not achieved the Sustainable Development Goal figure, but it is obvious that we are working together to reduce the numbers of women who die, and that is very significant for us. One major challenge we have is healthcare financing, and we have an economist here who I'm sure will speak to that more significantly. But when we look at our budget, we realize that in terms of healthcare financing, we have a major challenge. If you look at the social sector budgets for Ghana, the percentage of total government spending for social sector budgets has significantly reduced. It was 21.1% in 2022 and is reduced to 18.2% in 2023. And we need to look at government providing more resources for that. I'm happy that over the decades, when you look at the Demographic and Health Survey, 98% of pregnant women visit a healthcare facility for antenatal. And you have 88%, according to the Demographic and Health Survey of 2022, actually giving birth in a healthcare facility. And this has a direct bearing on the numbers of women dying. But like I said, it is still work in progress. We still have to do a lot more to significantly reduce the numbers of women who die from pregnancy-related causes. And we need that cooperation, we need more resources from government, and we also need for civil society, for traditional leaders, and for all of us to help to make sure that when a woman is performing this natural role that God has given to her for bringing life and for sustaining our populations, she is supported so that she does not die from this very simple, natural task and responsibility that she has been given by God. So thank you very much. I'm sure we'll have loads of questions and have an interactive session. Thank you.
Thank you so much, Mom. A round of applause for her, please. Thank you so much, Madam, for giving us those insightful comments, actually, I should say. I would also like to call on Dr. Fofie, Christopher Fofie of the Ghana Health Service, to bring us his remarks as well. Please take the podium. A round of applause for him.
Yep. Good morning. Thank you very much for the opportunity to be here. Yes, Ghana is at a very crucial moment where we're making significant progress in terms of our health. We are grateful to the Ghana Statistical Service for providing us important statistics that help us to evaluate the service that we provide. That clearly shows that over the years, some gains have been made. Now, when we look in that area, we see how antenatal coverage, that is women accessing at least one visit, has increased up to about 98%, which is good. But when we look deep into it, there are still some gaps, some quality aspects that are important to highlight. First among them, how many of our women are having 4 visits, which is the minimum number that's required to be able to have the impact that we expect. As the world is moving towards 8 antenatal visits, where do we stand? And here we see about less than half of our women are able to attend up to the 8 times. Another important element to look at is how many of our women come for their first visit in the first trimester. This is critically important because that permits us to be able to provide them with all the needed interventions during the antenatal period, and here we don't see ourselves doing very well. Right? Putting away antenatal, we also realize another striking thing. Very high women coming for antenatal, but at the point of delivery, which is just the essence of the entire antenatal care, we have about 88% of them delivering within facilities. Then at the postnatal level, we have by far more of them attending our facilities for care, which brings into focus a discussion. Why is it that we have many more women coming for antenatal, many more coming for postnatal, but few of them, there's a drop, not coming to deliver within our facility? That calls us as the Ghana Health Service, Ministry of Health, to do some level of introspection to see what is it around our facilities that's not making them attractive to our women. Why is it that they come, or traditional birth attendants or religious facilities are able to compete with the service and get many more women going into such areas to deliver, though under unhygienic conditions or circumstances that can be considered to be a bit dangerous for their safety. So with this in mind, then we see that there are gaps. We cannot say all is well. There are issues around quality of care, which most of us are aware about, and we are looking into seeing how to address that. How do we make sure that we have respectful care? When you get to the facility, you deliver there. The care that you receive from beginning to the end, how well is that articulated? How does that fit to the expectation of every individual, every mother in the Ghanaian space? How do we make sure that male involvement is encouraged? We are all familiar with the situation where our hospital facilities, most of them are old, and space to be able to have that male companion could be a challenge. How do we move to a new era where families can enjoy in the space of maternity homes or delivery rooms and enjoy probably being part of the process, cutting the cord, for instance, of their children and enjoying that special moment? These are all quality aspects of it. We've mentioned, it has been mentioned already, issues around commodities and supply. We're talking about blood, equipment, and all that. Looking at the general environment around delivery, we cannot say all is well. Still, at this point, we are unable to provide all the analgesia that women require during delivery and labor, which puts most of them to want to avoid most of our facilities. So putting all this into context, we see that there is a need to improve the quality of the services being provided, and that is directly in alignment with the Ghana Health Service Family Health Division's strategic objective or plan 2020-2025, which focuses on improving quality of care for maternal, child, adolescent care. And to be able to do that, one important component has been financing, right? So looking at the mandate of the Ghana Health Service, which focuses on primary health care, the strategy previously has been focusing at the CHIPS compound, where a lot of efforts are being taking place. However, with all this, it's clear that we need service redesign, and this service redesign strategy of the service is now focused on the network of practice. With this network of practice, the general idea is that the CHIPS compound or CHIPS zones will continue to exist, but how do we get the private sector involved? How do we get other sectors within the health space to come all together to form what will be a network? So at the sub-district level, the health center becomes the hub, and around a hub we have a number of CHIPS compound and chemical sellers and private facilities that include maternity homes, all working together to be able to maximize resources and improve outcome. It is believed that with this strategy, which is a service redesign, we'll be able to improve and attract financing into this area, and clearly we're getting support from some donors and governments all together to be able to improve the care. so that no woman goes to deliver and travels more than 30 minutes before getting to a delivery unit. These and many more are clear strategies that will help us to be able to turn around the tide, so that at the end of it, we'll be able to reduce maternal mortality. But more than maternal mortality, improve the maternal experience of every woman who delivers in the geographical space of Ghana. We want delivery to be an experience where women will be proud about that moment, will be happy about it, will remember it, and enjoy that experience for time to come. And for that to happen, there is a need for some sustained financing, there is a need for planning. There is a need for resources to be put together, get all resources and all that is required to be able to make this dream a reality. Thank you very much.
Thank you very much. Thank you very much, Dr. Christopher Opoku-Fofi. Shall we have another round of applause for him, please? And I hear one comment passing through the two messages we've had: the need for women to be secured and the children to be protected in working around our health sector, and of course the emphasis on re-strategizing to financing maternal health care. We'll go into details. We'll also go to the audience for some questions, and indeed, if there are recommendations from them as well, we will do that. But before that, let me also call on the representative from the National Health Insurance Authority, Dr. Abigail Kujo. She's the acting head of claims. I'm sure you've heard a lot about claims from the NHIA. She's going to give us her perspectives and even trickling it down to the CHIPS compound. Shall we welcome her with a round of applause, please?
Thank you very much, and a good morning to all of you. I'm happy to be here this morning in this very important discussion that's looking at sustainable health financing towards improvement in maternal health services. I'm here to represent the CEO of the National Health Insurance Authority, Dr. Bernard Okoboy. And before I continue, I'd like to situate this discussion under the context or the concept of universal health coverage. When we talk universal health coverage, we are saying this because of the drive towards Sustainable Development Goal 3, Target 8. That says achieve universal health coverage, including financial risk protection, access to quality health care services, and access to free, affordable, essential medicines and vaccines. So for Ghana, the National Health Insurance Authority is like the main driver for the country towards attainment of universal health coverage come 2030. So if you look at the concept of universal health coverage, there are three pillars mainly. So you're looking at the population that's covered, the services that is covered, as well as the amount of out-of-pocket payment or financial risk protection given in terms of what people have to pay at the point of service use. So with National Health Insurance Authority, we are looking at 95% of all ailments in Ghana being covered by the scheme. And when we talk about out-of-pocket payment, it means that if the service is covered or if it is part of the benefit package, our members are not supposed to pay anything at the point of service use. I don't want to go on in this direction. That's a discussion for another day as to what's actually being done and what the policy says. But this is what the policy says. And sometimes because people are not aware of the policy, people can be taken advantage of. So it's good that we throw this out there. So when you look at maternal health care services, we are looking at the concept of CHIPS. That's like the basic unit in the healthcare structure. So if you look at tertiary, well, now we have quaternary. I'm going from top down. If we look at the quaternary level, tertiary, secondary, primary, at the primary healthcare level, that the district hospitals, that trickles down to the sub-district and then to the community level. So at the community level, you have a community-based volunteer who lives in the community with the people. This community-based volunteer is linked to a community health nurse who is supposed to come from the CHIPS compound. And the CHIPS compound could be a CHIPS compound with a midwife or without a midwife. So this community health nurse or the midwife who heads the CHIPS compound is supposed to know everybody in the community, children, elderly, pregnant women, adolescents, so that there's the continuum of care. So for National Health Insurance Authority, we pay for services when it comes to maternal health care services. We pay for antenatal care, we pay for delivery, we pay for postnatal care. And we even cover the baby when it is born till 3 months under the mother's subscription. So if you're a pregnant woman and you are enrolling on the scheme, you don't pay any premium, you don't pay any processing fee for a pregnant woman, but you do need to prove that you are pregnant. So going forward, for antenatal care, to build on what has been said, where you're looking at focus antenatal, you should have 4 visits. National Health Insurance Scheme pays for 6 visits under antenatal care. It pays for 3 visits under postnatal. It covers delivery. In addition to that, if a pregnant woman is unwell and visits any facility with a valid National Health Insurance membership card, whatever it is that you are ill from, once it's covered by the scheme, you are not supposed to pay anything out of pocket. So the 5% of services that are not covered, maybe I have to touch a bit on that. That has to do with things like infertility and then medical examination and other program diseases that are being covered by another vertical program. So because National Health Insurance Authority does not seek to duplicate, because then there would be a wastage in the system. So for instance, if it's tuberculosis or HIV, we will not cover for tuberculosis or HIV, but we will cover for the related ailments to the tuberculosis or HIV. That was just to clarify the benefits package. So in terms of what we cover at the primary healthcare level, back to this CHIPS concept, we are looking now at assisting Ghana on the UHC drive in supporting primary healthcare through the lower tier facilities. That's looking at CHIPS compound health centers, maternity homes. So last year, there was this extended zonal stakeholder engagement to get these lower tier facilities to expedite their claims processing and submission to the NHIA. So we are actually going electronic so that it makes it faster and easier. But then we realized that our stakeholders, which are the providers, needed to be brought on board. So with the help of World Bank, we went around all the 16 regions of Ghana just to sensitize these providers on what they need to do in terms of expediting their claims processing and submission to the NHIA. So we are currently using the Claim IT app, and it was a very successful engagement from my perspective, because there were a lot of things that they were not aware of that we needed to bring them on board. So basically, when they process their claims and submit to us at the National Health Insurance Authority, we are looking at a program of expediting the processing of the claims and getting them paid within a space of 90 days. So for the claims directorate, we are looking at 30 to 45 days maximum to process these claims. Looking more at 30 days for the CHIPS compound and the tier 3 so that it can be moved on to the next level for payment. So that's what we are doing. And currently we had some issues from the CHIPS compounds or the lower tier facilities in terms of network access. And sometimes they're not able to submit their claims because maybe it was a bad network coming from the telecommunication company, which is beyond us. But what we are doing is that we've developed an Android version of the Claim IT app, which helps with the claims processing, which this will be rolled out this year, so that wherever you are, it's like having your phone with you. Everybody has a phone, so it's assumed that wherever you are, I don't believe that community health nurses will not call family, they call, they do all that. So we believe that once the phone can reach people from where you are, then an Android version of the app can reach the National Health Insurance Authority for your claims to be processed and paid on time. So basically, these are the things we are doing to reach out to ensure that the sustainable financing towards improved maternal health services. So I'm glad this dialogue is going on, and I hope that at the end of the day, there'll be a lot of insights and a lot to improve the service. Thank you.
Thank you very much, Dr. Abigail Kujo. Thank you so much. Shall we have another round of applause for her? Thank you for those details and bringing us some of the things that sometimes we don't get to hear on our news and other programs. I'll be calling Dr. Edusa Akodie. In the midst of this, I'm sure you've been hearing that we need to put in more money, we need to add more. How do we do that? Because if you look at the statistics that are available, in 2019, our financing dropped. And from 2017, or I could even start from 2016 up to 2020, COVID time, the instability of our financing in the health sector. Of course, when you have the overall, then you can send some to maternal health care and other areas. Dr. Edusa Akodie will be giving us his perspective as well. Is there a need to re-strategize, or there's really a need to have, should I say, political will to ensure that what we need for our health sector, we are able to give it? But before that, I want to call on Awal Mohammed, who is the executive Executive Director of Rise Ghana. He and his organization are on the ground to really pick the real information, just like Ghana Health Service, that is the implementing body. So Mr. Well will be giving us his perspective as well as regards what he finds on the ground. Shall we welcome him with a round of applause, please? Yes, please come and give us your message on the podium.
Okay, thank you very much, and good morning to my co-panelists and the audience. I think that...
please use the microphone for us.
Yes, thank you. I think the previous speakers...
The microphone on, yes.
Oh,
thank
yes,
you so much.
thank you so much. I think that my previous speakers have touched the meat of the substance of why we are here. And the emphasis I want to make is about the fact that when we talk about issues of maternal and child health in our grassroots, we need to focus on two areas mainly. One area has to do with, as Doc said, the quality of care. And that is for me why the role of private sector is very critical. There are certain things that government can do. There are a lot of things that the health insurance can do. If we approach the issue of maternal health using the health systems strengthening approach, where we talk about 6 major elements. One of them critically has to do with essentials, medicines, and equipment that the health workers need. Another aspect has to do with the health workforce itself. And of course, what is very dear to my heart is the issue of governance and leadership. And by governance and leadership, we are talking about the role of the community in ensuring that the quality of healthcare is achieved. And so we are proud to work with Star Ghana at the grassroots level. To the speaker from Ghana Health Service talks about networks of practice. So we have instituted a series of community of practice where people who are engaged in the continuum of care for maternal health are coming together, reviewing the quality of services and demanding that the best things be done. We are in an era of universal health coverage where basically nobody should be burdened in terms of financial burden if they seek to access. Nobody, I mean, no woman should die exercising her right to give birth. I mean, the person's only merely exercising their right to give birth, which comes biologically, which is necessary for continuing procreation. So in an era of universal health coverage, the cost should not be so prohibitive that people will have to choose to go to health facilities or not go to health facilities. So key important thing is the community of practice is able to, for instance, call the one in charge of ambulance services in a district to ask them, why is your ambulance broken down? And if you come from a rural area, you would understand that emergency transport is very critical, and that's another important role the private sector can play. So we are looking at the ordinary aboboya in the community, the taxi that operates in the community. They have a role to play. They are available and they are charging a certain set of services, charging a certain amount of money for certain services that they provide to the women. So working with private sector ensures that these people understand the dynamics and they don't charge fees that are exorbitant to the women. We also spoke about the community of network of practice, and we are excited that the USAID have followed that, has given the Ghana Health Service an amount up to, I think, $50 million to support this network of practice. And so when we talk about private sector, for me, for those of us those who are listening to us outside the ambience of this room, we need to look at the low-hanging fruits. We don't necessarily have to look at the high expenditure. It's very important we look at the high expenditure, because as we speak, 42% of our health facilities do not have running water. And running water is so critical in health delivery, particularly maternal health, because sepsis, that is infections, is one of the leading causes of maternal death and newborn deaths in the country. So investing in these areas is very important. So private sector that is listening to us, the companies and others, we can invest in washing health and we can help reduce this significantly. Number two, invest in quality issues. And quality improvement issues has to go with the, you remember I spoke about the health building blocks, and one of them is the health workforce. I mean, nobody should go to work and the work environment is not conducive or appealing for them. So we need to have the right staff with the right morale in our health facilities. And one of the ways that civil society can do, like Star Ghana is partners do, is to build the capacity of staff. So setting up this community of practices, enabling staff, give feedback to communities, enable communities participate. There's a health facility somewhere in Upper East region where they didn't have a space for mothers who come to be consulting. They couldn't separate the mothers from other people. And you know, the Ghana Health Service will tell you that there are 2 levels of privacy when it comes to maternal health that are very critical. One of them is auditory privacy. The other is the visual privacy. I will just explain that briefly. Auditory privacy has to do with the fact that when I'm consulting you, the third party should not hear what we are talking about, unless the person is lip reading. The other thing is the visual privacy. There should be a barrier between those who are doing the consultation and the service seeker. But some of the health facilities, unfortunately, do not have enough space to be able to provide these critical rights-based necessities for quality of health. So a community of practice is able to work with the community and they make up a structure and solve that problem. So the role of private sector is very, very critical, and it can come in a small form as well as in a big form. So conversations like this, we need to open it up and let the community's role come out strongly, and then also invest in the soft aspects so that communities can be able to hold duty bearers accountable. For instance, my colleague from the health insurance talked about the fact that they cover up to a certain number. Is this feedback known to the community? So one of the things we are doing under the Star Ghana project, which is funded by the Foreign and Commonwealth Development Office called GREP, is that we are collecting a series of data in terms of the experience of women who are accessing maternal health services using the health insurance to really test what is on the book and what is on the ground. And we are picking some signals, and at the appropriate time we want to make this public to influence policy. And Star Ghana is very supportive of this process. So we need to sum up, I think that if we want to talk about improving maternal health, i.e. reducing maternal death, I mean, sometimes I am worried about the targets. Why shouldn't be 1 or 0 over 1,000? I mean, sometimes it's but we are coming from, we need to make ambitious as well as calculated targets. So I understand the Ghana Health Service when they say that for every 100,000, we want to reduce it to this number. So it makes sense, but looking at it, we can really, really push further. And for me, to do this, we need to invest, among other things, in 2 main things. Quality improvement, number 1, and then 2, community empowerment. When communities are empowered to take up the issues of maternal health and to support the process, then it will be bringing up a lot of significant improvements. When there is quality improvement, the health workers would deliver their best. They will not be infected. There is something they call nosocomial infections, where you get sick because you go to the hospital and interact with the environment. This will not happen. And lastly, I think it's very important for us to be able to consider the role that the media plays in this space, and then also male involvement. I mean, people go, there are certain services that the health insurance doesn't cover. And when our mothers or our wives, our sisters who are pregnant go for services, they are asked to purchase certain things. So when the man or the partner is not involved, they are not able to support this. They think that the women just want to collect money to do other things. So male involvement is very critical. So I would sum up by saying that the role of the private sector is critical in these areas. Promoting community empowerment, promoting male involvement, or what the Ghana Health Service called companionship, and then investing in quality of care. Thank you.
Thank you very much. A round of applause for him. Thank you so much, Awal Mohammed, Executive Director of Rise Ghana. Thank you for bringing us that view as well. And he kept emphasizing the role of private participation in this whole thing. So I believe this gives us a perfect, should I say, picture and perspective of how we should go about this. And that is where Dr. Edusa Akodie will be coming in. Because he's talking about, Awal is talking about private participation. But we also do know of the core responsibility of the government to ensure that women and children are safe. So I will call on Dr. Edusa Kodia right now, economist and lecturer at the Department of Economics at the University of Ghana, to bring us probably that perspective. How much should the government contribute and how much should private participation be? Shall we welcome him with a round of applause, ladies and gentlemen?
Good morning. And thanks to TV3 for this invitation. I guess always I'm the one to look for the money. I should bring money because there's a problem to be resolved. I like the flow of the conversation. Our earlier speakers have laid down the problem. Others have talked about what should be done. And my job here is to tell us where do we get the money from. And healthcare financing, the source of the financing should have certain qualities, certain features. Number one, it should be sustainable. Number two, it should improve quality. Number three, it should provide equitable healthcare. Number four, that source of finance should be predictable. It's not like you want to go and sleep and then wake up one day and say the money is not coming. It should be predictable. We should be able to budget for it, and it must offer transparency and accountability. So we look at the history of healthcare financing in Ghana. We have tried free healthcare in the colonial times. In the 60s and 70s, we tried fee paying. We also tried cash and carry in the 90s. And today we have the health insurance and then co-payment, and not co-payment, but also out-of-pocket payment. The health insurance is both public, the NHIS, and also private health insurance. I know some of us also have health insurance. Health insurance is good so that we can pool resources to finance healthcare for that. So now let's look at what currently Ghana is doing to finance its healthcare. Number one on the list is NHIS. It was introduced in 2003. Right now, I think, Madam, you can correct me, the enrollment is around 12 million Ghanaians. 17 million now, that's good. So 17 million Ghanaians are enrolled on it. And so how does NHIA get the finances to provide healthcare services for the 17 million subscribers? First on the list is the NHIL, and then also the state contribution. And it will interest you to know that NHIL and then the state contribution accounts for 92% of all incomes to the NHIA. They also have premiums and processing fee, which accounts for about 5%, 5.6%, then investment income, bilateral donors, other incomes, government of Ghana, annual budget support. That is for the health insurance. And now, if somebody is not subscribing to the health insurance, any health insurance, then you must do out-of-pocket payment. Okay, when you go to seek the health service, you must pay it yourself. Some countries are practicing co-payment. Ghana, I'm not sure we are doing co-payment, but if you are not a health insurance subscriber, you'll be doing full cost payment. The government of Ghana is also supporting the finance of healthcare with its budgetary allocation to the health sector. So it's also another financing that we are experiencing now. And lastly, the donor community. There are some bilaterals, multilateral donor communities. I think in President Kufuor's time, we had free maternal health care service. I don't know how long it lasted, Anna. Why are we not having the free maternal health care service again? Okay. It's still ongoing. Yes, that's good. Ongoing. Okay, then that's good. Then why do you have a problem? This is free. Anyway, we'll discuss that. Okay, so going forward, where can we get the money from? We have the problem. Our mothers are dying. Our sisters are dying. Where do we get the money to resolve this issue? Whenever TV3 calls me, they know that the first thing I'll mention is the extractive sector. And right now, almost everywhere I go, when they see my face, they look like extractive sector. Because God has blessed this country with a natural resource. And so all the things I'm going to propose today, where we are going to get the money from, it can be a short-term measure, medium-term measure, or long-term measure. Some things that we can do within 1 year, others we can do in 3 years, the rest we can do in 5 to 10 years. So I'll put all together. The extractive sector. Because we have examples from Botswana, Canada, Saudi Arabia, Qatar. These are resource-rich countries that are doing well to mobilize funds from their extractive sector. God, in his wisdom, has blessed this country with so many natural resources. According to experts, the value of the natural resource we have in this country is about $10 trillion. Ghana here, in the ground. 10, you know trillion? Students are looking at my face. 1,000 times 1,000 is million. Million times 1,000 is billion. Billion times 1,000 is trillion. So all the natural resources we have in this country, the value amounts to $10 trillion. That's about half the GDP of USA. So if you are this rich and you are looking for money to finance maternal health, where else do you look for? You look for the extractive sector. And why are we not getting enough from the extractive sector? It depends on the contracts that we have signed. I am not an expert, but I listen to the experts. There are 3 types of contracts. Let me briefly talk about extractive because it's so much dear to my heart. 3 types of contracts. The first is a service contract where the government of Ghana will contract a company, private company or public company to explore and produce, and then you pay them for the services, and then you take your gold. So let's use gold for example, as an example. Then you take your gold, then you own it. You pay them for the service they have rendered, you own your gold, and you can go and sell. Now, that's the best of all the contracts. The second best is a production sharing contract, where you are a private company, I am government of Ghana, I have gold in the ground, come and produce. When we produce, we share the gold. You take your half, I take my half. All right? Now the third one, which we have been doing for centuries, hundreds of years, which is keeping us still poor, is a concessionary contract. When you do concessions, you give ownership of your resources to somebody. So we have the gold, but it is not for us. We have crude oil, but it is not for us. Today, we have lithium, but it's not for us. Why? Because we have signed the contract in such a way that we have transferred ownership to the producing companies, and they come back to pay us taxes and royalties. This is not a practice in Qatar, Saudi Arabia, Canada, even in Africa here. The practice has been production sharing. Go to Botswana. The Botswana government has 55% share in the diamond that is being produced in Botswana. Go to Nigeria. The Nigerian government has 51% share in the oil produced in Nigeria. Come to Ghana, we have about 16% share. That's a shame. And so we cannot be the #1 producer of gold in Africa today, and our mothers will be dying. The #1 producer of gold in Africa is Ghana. The value is about $6 billion. Crude oil is about $5 billion. Add lithium. This year, we are going to start producing lithium of almost $7 billion. Put all together, we are talking about close to $20 billion in a year from just 3 natural resources. $20 billion in a year from just 3: gold, oil, lithium. And the story about lithium is interesting. God in his wisdom, God loves this country so much. Do you know why? Because the whole world is moving from fossil fuel to clean energy. And the crude oil that we have discovered, according to experts, the ones we are producing now will dry out in 2035. So by 2035, it will start finishing. And God says no. Even if I don't give you more crude oil, I'll give you lithium. Because lithium is now the order of the day. It is being used to produce batteries. So if the whole world is going clean energy, I'll bless this country with lithium. What should God do for us again? He's giving you lithium, and you have gone to sign the same contracts as the previous ones, which has impoverished this country for centuries. I'm not talking about tens of years, centuries. Because in 1911, gold and cocoa were our major export commodities. Today, gold and cocoa are still our major export commodities. So centuries. So the first recommendation for us to get enough money to finance healthcare is to advise our government and all stakeholders that the contracts that we have signed in the extraction of natural resource is not the best. We should go back. I know it will take some time, maybe 2, 3, 5 years, but we have to start from somewhere so that in the next 5 years, even if it's not us, our children will be able to enjoy free maternal care, free healthcare, quality healthcare, and then we'll all be happy because it is done in Libya. It is being done in Botswana. It is being done in Canada. It is being done in Saudi Arabia. Why should Ghana be a resource-rich country and still be talking about how to get money to finance healthcare? So that's a long-term solution. In the short term, we must increase the royalties of all the mining companies in the country. The new contracts that we have signed on lithium is giving us 10% royalties. This lithium, we are now going to produce it this year. But you know what? The gold that we have been mining for centuries, the royalties is just 5%. So how can you charge lithium companies 10% royalties, and they are now coming to start work, but those who have been with us for years, you are charging them 5%. So I know the government is listening to us. Today, tomorrow, these royalties can be increased today and tomorrow. So it's a short-term solution. We must find, and I've done my calculation, it's going to give us another 2 to 5 billion cedis if you increase the royalties. The next one, which is a bit controversial, but I will say it because we are all looking for solutions, is the COVID-19 levy. We have been told by the government that the COVID-19 levy was to help them pay back the loans they contracted during COVID. So some people think that COVID-19 levy is about when the virus is around. So they say that the virus is no more. Why are you charging levy? Okay, so it is for the government to pay back the loans that they contracted during COVID. And others are calling for the scrapping of it. I do not support that. In the midst of fiscal challenges facing the government has done domestic debt exchange. They are going for the debt exchange programs. Ghana government doesn't have money. There are fiscal challenges facing this country. This is not a time to call for the abolishment of a levy or a tax. I will propose that we take, if they are finished paying the COVID-19 loan, they should keep the COVID-19 levy and channel it to healthcare financing. Because COVID-19 is a health issue. If you are finished paying the COVID-19 loans, we shouldn't scrap it, we shouldn't remove it, we should keep it and channel it through to healthcare financing. The other one on my list is the capping of NHIL. But let me say kudos to you. I've looked at your data. You are not making losses. You are making what you call income surplus, right? Yeah, income surplus, which is okay because we know that your money is not enough, but you are able to live within your means. This NHIA, they are suffering from what we call capping. And I must eat the humble pie, moderator, because I was one of those who advocated for the capping of the earmarked funds because government was facing serious fiscal challenges. So some of us advocated that the money that you transfer to the government units, like District Assembly Common Fund, Road Fund, Get Fund, NHIL, there should be a cap on it so that government can have more revenue to do other things. So this one, I'll eat the humble pie. I'll say that I was part of those proposed there. But if things get better, maybe from next year in 2026, they should remove the capping. Remove the capping and allow NHIA to get their full amount that is supposed to go to them. Directly linked to the capping is what we call automaticity. Automaticity. What is it? NHIL will pay 2.5% on all the items that we buy, and it's supposed to be transferred to the account of NHIA. They have accounts with the Bank of Ghana, and they are supposed to use it directly So it must reflect in the accounts and they use it. That is automaticity, direct. But what we see in Ghana is that it doesn't get to them. When the monies hit the accounts, then at the discretion of the Ministry of Finance, they decide on how much they should give to them. Okay? So the automaticity we are proposing that whatever money goes to the accounts of NHIA must be directly used by NHIA. The government should not use any amount. They should allow them to use their funds. Then community revenue mobilization. We have been talking about property rate. Maybe we should allow our local assemblies to collect their property rate and use some of them to finance revenue. We can advocate for hospital waiver. That is for people who have low incomes. If somebody goes to give birth and we know that using the person's Ghana card, we can assess the income level, and we know that the person is not able to or is not financially sound to be able to pay the health, we can waive, we can reduce the cost or scrap the cost of maternal health care for that person. Then donor community, we have to appeal to the donors. There are rich countries around. They have been extracting our natural resources. They have been doing that for 500 years. So they have enriched themselves with our natural resources. So we must go back to them and appeal to them to come and help us.
I'm
help
sorry
us.
to interrupt.
Yes.
Doc, you have to be wrapping up
yes.
in about a minute or two so we can continue with the other phase of the conversation.
Just two. So donor community, the private-public partnership, and lastly, it is not money, it's about time. My brother talked about it, that the healthcare should be within 30 minutes drive or so. There's something we call the price of time. As economists, we're always interested in opportunity cost. So the price of time is also important. How much time is spent to travel to the health center, how much time is spent to wait to receive the healthcare is also important, and these must be addressed. Thank you, Madam Moderator, and thank you, everybody.
Thank you so much, Dr. Dusa Akodie, economist and senior lecturer at the Economics Department at the University of Ghana. Shall we have another round of applause for him, please? Thank you so much. A lot of detail in just a very short time, very loaded, and I love the area about the need for us to relook at how much we get from the extractive sector. And I'm sure you remember the lithium conversation recently. You wouldn't want to go into the political discussion there, but obviously the need for us to negotiate better. And the argument that if you want to have a stronger hand in negotiation, you should also have been able to have some investment in that sector as well, because the Saudi Arabia and the Qatar and the countries that the Dr. Dusa Akodie was just talking about, exactly, these countries have had some level of investment as well. Exactly, so that's something that we may want to go into it. But let me just go through again what we've been able to gather in these minutes that we've had, and then we'll go for one round of really moving forward as regards what we need to change. That's in addition to what you said so far. And then some questions from the audience. And of course, I said earlier, if you have recommendations, it could be the golden one that the government and stakeholders need to fix the problems we have on our hands. I will start off from what former gender minister said, Nana Oyebampo, when she talked about the fact that we have data and we should be able to use the data. She also talked about lack of access, abortions, the need for us to look at the system so people can feel free to go to the proper institutions to have abortions and not drink concoctions. I think Dr. Fofie also mentioned something that we do know, the unorthodox means that people prefer to use instead of going to the health sector. And that reminds me of a story in 2013 when I was in Jirapa, which is a district in Upper West region. And at the time, there was only one doctor in the regional hospital who had to even deliver his own wife, which is unethical in the medical field, I believe. And that place, there was a man, a farmer who had lost his wife, and not just the wife, but the baby as well, because they were in the deepest of one of the towns in Jirapa, and it was time for her to deliver. she had to be transported on a plywood on a motorbike to the Wa Regional Hospital because they didn't even seem to have a CHIPS compound around the place. So in that journey, she died, and the man was left alone, having to take care of the other children that they had had earlier. And just last week, or it was rather this week, I think it was Monday or Tuesday, there was another conversation, another senior economist from the University of Ghana who was talking about knowing about 4 people who had died alone because the roads were bad and the CHIPS compound. I know that for a number of years we've been trying to build more, but you don't have the skilled personnel there. In 2013, when I was in Jirapa, I went to one of the CHIPS compounds, no health personnel. So imagine somebody has an emergency. Who is going to take care of that person? So these are issues that we really need to look at. But just to give you some more data before we have this very short recommendation, as it were, then we'll take the questions from the audience. CHIPS compound established in 1994, and we also do know, I think that Madam Oyebampo, you talked about the financing, a bit of it when you were giving your view on it. 2019, we had 3.5% of our GDP going into the health sector. And we also understand that donor support has been dwindling since 2010. Between 2015, I'm just giving you some statistics so you know how serious the problem is and the need for us to re-strategize and deal with the problem. Between 2015 and 2020, development partner funding for health sector decreased by an annual rate of over 10%. That is huge. If you're looking at governments that are always complaining that they don't have enough funds and private sector trying to find their way in this. And also, in terms of proportion of health budgets represented by donor funding, more than halved between 2016 and 2020, down to 6.3% from 13.2%. And of course, World Health Organization also proposing between 4 to 5% of our gross domestic products going into health expenditure. And we also do understand or do know about the Abuja Declaration and some of the targets that have been set for us, including countries allocating about 15% of their annual budgets to the health sector. So obviously, if you're looking at the institutions that are involved and the stakeholders, they understand that there's a need to invest in health. Just like education, if you have health, you will prosper. So I will go first to, or I'd rather come to you from the NHIA, Dr. Abigail, and just ask you the question about the CHIPS compound. I just narrated the story of even lack of personnel there, and there have been some issues. I'll just mention some of the data we have again, just to put your answer in perspective. It says that some of the reasons a number of women and babies die are health system failures that translate to poor quality of care, including disrespect, mistreatment and abuse, shortages of essential medical supplies. We had it in our presentation. And earlier, I was talking about the NHIA and the need for us to reimburse in time. I know Dr. Okoboy recently talked about a huge improvement in this area. How would you say you're monitoring, particularly in the rural areas? I know you mentioned or you talked about going into digitalization. I'm just using my words. But in the rural areas, you understand that people don't have access to these. How do you monitor to ensure that everybody, whether you're in a car, you're in a town, or the most typical of villages, you still can have access to health care?
Thank you very much. This is a very interesting question. And as I was listening to you, I liked the fact that you used the health system and not the health sector, because it is in fact a system of the building blocks that have been mentioned, as well as the most critical element, the people. So the people in the health system affect what comes out of the health system, because the people are affected by the hardware as well as the software. When you're talking about software issues, it has to do with your conscience and all that. So back to the story you talked about, The main issue is a road network. A man on a motorbike trying to move his wife to a health facility. The bad road network is a different sector. It's not the health sector. So basically, we are looking at health in all sectors approach, where every sector should be talking health. And we can't, if the Ghana Health Service or the community, because that's also a multi-sectorial approach, the district assemblies decided to set up more CHIPS compounds, and people cannot get access to the CHIPS compounds, there'll be a problem. So basically, we all need to talk health. There's the talk about how we get the National Ambulance Service together. That's another sector that we need to engage in this whole discussion of maternal health care. It's a system and it's people. And there are some networks or interlinkages between this system, and we need to build on that or tap into that. So when we come to what National Health Insurance does, what it says is that we will credential the health facility, be it a CHIPS compound. If I may tap into what Doc talked about, that they are now looking at networks of practice. In the networks, you are supposed to have a CHIPS compound, a health center, or, the hub and the spokes. If it's a licensed chemical shop, you are supposed to have these. You can't have these beautifully done on paper and then practically, if we don't do what we have to do as a country, we'll have an issue. So let me try and stick to what we have to do as National Health Insurance Scheme. We will credential the facility. If it's a CHIPS compound, there are certain things we're expecting to see. If it's a health center, there are certain things we expect to see that will feed into quality. So like I mentioned earlier on, there's a CHIPS compound with a midwife and a CHIPS compound without a midwife. The CHIPS compound that has a midwife can carry out delivery services, which the CHIPS compound without a midwife necessarily is not supposed to do. So they are supposed to refer. But if it's an emergency delivery, say the woman gets there and the head is in the, if I may use the term vagina, the baby's coming, the CHIPS compound cannot say, okay, let's bundle you in a taxi or a motorbike and send you to the midwife. No. So in addition to that, there has to be that linkage for referral, which is very critical. So we will credential you and pay you for the service you render by virtue of the tariff that is allocated to you. I'm trying to stick to National Health Insurance as much as possible.
I mean, it is obvious that this is a multi-sectorial kind of thing, so we cannot work in isolation.
No.
You can play your part, and the other departments can play their part.
Yes.
So you're still sticking to what...
Yeah, so what it is that we will do our part of checking that you have all the things that amount to quality, and I believe HIFRA also does the initial thing of accrediting you as a health facility in the first place. Then we follow up with the National Health Insurance Scheme credentialing. But then, in terms of implementation, when we come back for a reassessment, we carry out clinical audits to see that, for instance, the claims you submitted as in, say, March last year for services you rendered, we might come back, a team from quality assurance, to the facility to see all these services, were they actually carried out as they were supposed to be carried out. The thing, though, to ensure that the health system delivers on what it's supposed to deliver on, is the element of accountability. And you realize that there are papers, or if you look at Brinkerhoff, he says, sanctions give teeth to accountability. Where there are no sanctions, you can't hold people accountable. These sanctions don't necessarily have to be hard sanctions. Even if they are soft sanctions, they make people sit up. So I feel these are some of the things we need to look at. And then again, if you are looking at National Health Insurance as it is, we all need to hold ourselves accountable and ask ourselves, what is it we are doing? What can we do better in the whole system as a whole? Yeah, I don't want to...
If I can come in.
All right.
I think most of us will agree that the National Health Insurance is not delivering. It is not working as it should to enable Ghanaians access healthcare services at minimum cost. That Ghanaians are presenting at healthcare facilities, and we are, even though we are National Health Insurance, we're holders of the cards, we are having to pay much more than we expect to pay. And this is affecting quality of care and also affecting the Ghanaians' ability to receive the healthcare services. And it boils down to cash. Government's ability to pay. Just like my brother, Dr. Sarkodie said, Simple, very simple. This is problematic. And also with respect to a woman going to the hospital when she's pregnant, even getting money for transport to take to the hospital sometimes becomes a problem. And so I'm happy to read the figures and see that at least we have 98%. And we have come very far as a country. Even sometimes, culturally, we have challenges. A woman is pregnant, she's in labor, you stop a taxi. I don't know about Uber and Bolt, but you stop a taxi to transport the woman, and the taxi will charge double. Because culturally and traditionally, if the woman gives birth in the taxi driver has to perform certain customs and cleanse his taxi. So that cost is transferred to the woman. So these are the realistic challenges. And you realize that even feeding, like in the north, I remember a few years ago, a woman received an international award because she prepared a pottage. Like there were women in some parts of the north where when they give birth, they have to be giving some porridge of some sorts. And because it was not available in the healthcare facilities and the hospitals, they preferred to deliver at home. So one traditional nurse just was innovative, and she prepared that porridge and put it in the hospital or wherever the women were delivering. And just by virtue of that, there was an increase in the numbers of women in that community coming to the hospital. And that's why the gentleman who spoke from, is it Arise?
Awal.
Awal. Yes. I mean, he's speaking about this private, private government participation. That is very, very important. So these are some of the basic challenges.
So we'll come back for the recommendations, but Madam Grace Enchiachu, who is Senior Global Advocacy Advisor for Sight Savers International, wants to make some interventions. Would you please give us your view as regards exactly what you...
Thank you very much.
Okay, can we hear her? Please go ahead.
Okay. So thank you very much for the opportunity, and it's been an interesting dialogue, acknowledging the progress, but still also highlighting some of the key gaps that still do exist. So that's been interesting. In the conversation, though, I haven't heard anything about how inclusive those statistics are. So I heard few of the keynote speakers talking about data. We have done quite a bit on it, but how disaggregated is it? So I'm particularly interested in persons with disabilities, for instance, and in all the discussions, without clear disaggregation, we may go on patting ourselves in the back, however, leaving significantly key gaps. So persons with disabilities are being left behind, and when it comes to maternal health, really the stigma and discrimination when you get to the hospital. So there are a lot of them who will choose not to even go to the hospital just because of the stigma and discrimination. I listed quite a bit of key things I wanted to talk about. So data disaggregation, then health communication. So when it comes to all that we've been talking about, the gains, actually, who are we leaving behind? So the National Health Insurance is doing what they can. There are still gaps. However, how much of the information is out there in accessible format for everyone to really get to know what is available? Health communication gap when it comes to persons with disabilities is huge. A case in point is when the COVID pandemic struck. There were information going around, but there were significant people who were not getting this information just because the information was not being delivered in accessible format. So that's one. And when it comes to even accessibility, physical access in our hospitals. So those are some of the key gaps I was really hoping to hear flagged in this conversation. And then health system strengthening, I heard a bit of it, and then particularly around accountability. So yes, a bit of conversation around why people choose not to deliver at the hospital. Those who are ill-treated, what sort of systems are in place to bring a bit of accountability around it? And even when we start talking about health financing, yes, there are gaps. And we talk about donor fatigue. We also need to really significantly pay attention to accountability on the ground. So there are conversations around the fact that the National Health Insurance does pay for certain things, but at the hospital, you go, and the reality, like the former Honorable Minister was talking about, is that out-of-pocket expenses are exorbitant. And so for those who are farthest behind, it just doesn't work. And so most of the time, yes, there may be facilities, there may be structures in place, but they would choose not to go. Or even saying choose may not be the word, but they cannot just afford to do it. And when you look at the whole system, the health system, obviously when there are gaps for even, let's say, able-bodied persons accessing health, let's look at what it is that the barriers are for persons with disabilities, especially those with physical impairments. So that would be my few comments. Thank you very much.
Thank you so much. A round of applause for Madam Grace Entry-Achu. She's Senior Global Advocacy Advisor for Sites Savers International. Let me remind you that we're still live on TV3 and on our social media platforms. In the next minute, we'll be crossing over to the newsroom so that we'll have the midday news stream live. But this program still continues with live streaming on all our social media platforms. So you can continue to monitor the discussions happening after TV goes to take the news, but you can continue on our social media platforms. But once again, thank you very much, Madam Grace Entry-Achu, with Site Savers International for your intervention. But the things you said actually tie into my next question, which is to Dr. Fofie of the Ghana Health Service, because the Ghana Health Service is like the implementing body that, you know, goes into the communities, the CHIPS compound, and I believe even the NHIA, there's a bit of collaboration and authority and, should I say, subordinate when it comes to ensuring that we have the best healthcare in our communities. And I think in our conversation earlier with you, Dr. Abigail, I mentioned the hard-to-reach areas and how you were monitoring events. But Madam Grace Entry-Achu talks about accountability and ill treatment. And those are, especially for ill treatment, you will not just find them in the rural areas, but also even in the capital city. Because I've been to a hospital where a lady was just at the counter waiting to fill, you know, when you go there, you need to kind of cross-check your card and all of that. And because she wasn't looking visibly sick, she was ignored. I was there. I was at the hospital myself. She stood there. She was trying to get attention of nurses and the other health officials. Nobody was minding her until right before all of us, she collapsed. The moment she collapsed, they rushed to bring in the stretcher and just, I mean, that was when they had to take care of her. But it didn't have to take her collapsing before the health officials would realize that it was important to pay attention to her, even if she wasn't visibly looking sick. So that's why I want to come to you, Dr. Christopher Fofie. And earlier in our conversation, we talked about